So I'm Dr. Allison Boyle. I went to UT for medical school. I also went to UT for residency in neurology, and then I stayed for a fellowship in movement disorders. And then I was faculty there for 6 years. And I was having clinic both in downtown and in the Woodlands, and I built up a clinic out here in the Woodlands with this great population. And I grew a clinic from 1 day a month to now full time out here. And we have a great program, and I'm now with Memorial Hermann, and we are doing deep brain stimulation here at Memorial Hermann. And this is a great population, and we are just going to really serve this community, and it's really exciting. I'm a movement disorder, so that means that I do like Parkinson patients, I see essential tremor patients and dystonia patients, patients with spasticity or increased tone from like stroke or brain injury. And so for these patients, we do medical management. I also can do Botox injections for the spastic tone or dystonia. And then we also do deep brain stimulation, which is for Parkinson's disease patients and essential tremor patients and for dystonia patients. And that is an amazing, amazing treatment that we have for these patients that really gives them back a huge quality of life that is so, so important to them. And so I see patients from teenagers through the rest, all the way up to I have 90-year-olds, and we just treat each patient and do whatever we need for that individual patient. So when we pick candidates, we have to pick depending on what their diagnosis is. So for Parkinson patients, we have to know that they actually have regular Parkinson's disease and not one of the kind of atypical variants, because we know that Parkinson patients respond really, really well to the therapy. So guidelines are they have to have had the diagnosis for about 4 years. And then when they start to have difficulty with medications wearing off too early or not working, or they're having side effects of the medications, then we start talking about the surgery. So for Parkinson's, we have two different targets because there's two different types of Parkinson's. There's tremor dominant, and then there's a stiff, rigid dominant. And so for each one, we have that specific target that will help all of the symptoms of Parkinson, but then the tremor one, more tremor, and the rigid one, more of the stiffness. And so the people who are candidates, we make sure they have Parkinson's. We get neurocognitive testing just as a baseline. And then we do the surgery, which is 2 parts. I think that'll be talked about a little more later, the actual surgery part. But the patients are awake generally, and we do testing in the OR to make sure that they respond and that it's not causing any side effects. And so we are able to turn the stimulators on in the surgery, and you can just instantly see the tremor goes away or their stiffness resolves, and it's amazing. And then we turn it off. And then they have to wait a few weeks, then they come back, and then we program the battery. So for Parkinson patients, we're usually able to come down on the medicine so they don't have to take quite so much or quite so often. And then we can always program as they change, with the disease, and we can kind of change the programming to kind of keep up with them. For the essential tremor patients, they generally can come off medication. So medicine has about a 75% chance of controlling the tremor or controlling it 75%. But with the DBS, then we know that we can get at least, if not better, 99% control of that tremor, and they usually can come off all their medication. So for essential tremor patients, they're candidates when either the medications don't work, or if they have side effects from the medicine, or they're just not having the control that they need to be able to do their normal daily activities. So that's when we go to surgery for those guys. And it's the same process, 2 stages, test them in the OR, and then when they come to us, we program them. And the essential tremor is really interesting because over time, as the stimulators are on, it generally breaks the cycle of that tremor. And so if they happen to turn off their DBS or, come down on it, it generally is better. Their tremor is better over time, just having that stimulation in there. And then they can come off their medicines, which is really nice. So that's a great intervention for our patients, and it really, really improves their quality of life. And it's like instant. So it's really satisfying, and it's just amazing to see in the office and in the OR. It's a great thing. So that's the really exciting thing. So for the first time now ever, we actually are able to do a stage 1, so the first stage of DBS here in the community. We now have a fantastic neurosurgeon that's been doing this for years, and he's now here with us. And we're able to serve the community at home, right here. And they're able to get, stage 1, stage 2, and they're able to get programming right here in the community. And that's an amazing thing. Everybody else in the greater Houston area has always had to go down to the medical center for this surgery and for programming, because all of the movement disorder people are generally in the medical center. So this is the first hospital to offer it out, outside of the medical center. And we're doing a great job. We've had some really good outcomes, and we're going to continue. I think it's important to say that yes, this, there is a huge population of idiopathic regular Parkinson's disease patients up here in the Woodlands and all the surrounding north, area. And so there's a huge need for a movement disorder specialist and a DBS specialist, to be able to have that comprehensive care. The numbers are just astounding out here, and I'm not really sure why, but it's a great community, and I love to serve it. But we are doing a really good job with being able to get people in now in our full comprehensive neuro center, which is growing out here in the Woodlands at Memorial Hermann. Now I think we have every subspecialty in neurology up here in our neurology group, and neurosurgery group, and that's really amazing for I would say a community hospital which is growing and not going to be the second medical center, I think, pretty soon. So it's a big growth out here. The big thing I think to drive home is that because this is such a prevalent disease, especially in this area, the disease does not just affect the patient or the person, the disease affects the family, right? So we have patients who are a slave to medicine, for lack of a better term, because they have to take their medication for Parkinson every 2 hours, some every hour and a half. And so some people are incredibly disabled because of that. They're unable to walk, they're unable to go enjoy their families, and so it's not just the patient, but usually the spouse as well, because they're having to make sure the medications and make sure that they don't, miss a dose. And it becomes this encompassing thing to have over the family. And so we have patients that, have had this disease for many years and they are a slave to all of it and they can't do anything. And we get them medically managed as much as possible. But then, for DBS to come in, it's a life changer. I have so many patients that were wheelchair bound that now have the stimulators, and with programming, they're able to walk and they're able to buy an RV and go around the country and see their children and their grandchildren. And, not only does the patient get their life back, but so does the spouse. And so that's really important. And so for some people who are kind of, on the fence or, a little worried with the surgery, because yes, it's a brain surgery, it's a little bit daunting. We do have patients and families that are more than willing to talk and tell their story and kind of help these other people kind of make it through the transition and just have a much better quality of life and get their life back and get on, and just enjoy things again, which is amazing. Nothing else in medicine can you do that is such a great intervention that it's like instant and it does such an amazing job in sometimes within 5-10 minutes of programming, the patient is up and walking. So those first-time programmings are the best. So that's what got me into it. I saw a surgery when I was in medical school. I was doing a neurosurgery rotation. And I was watching Dr. Simpson then put in stimulators in somebody with this terrible tremor, and they turned the first side on and she just stopped. And I just had no idea that this was even available. And I just was amazed. And so that got me hooked back in medical school. We're still doing it now. We're doing it, and the technology's gotten better, so we're doing a really good job.
My name is Sam Javidan. I'm a neurosurgeon here at Memorial Hermann, the Woodlands Medical Center. I arrived here in July of 2020. I've been in practice for over 15 years. I'm a board-certified neurosurgeon. I specialize in adult neurosurgery with a focus on movement disorders, tumors, and spinal conditions. I was born near Washington, D.C. I grew up in a suburb of Washington, D.C. I attended university and medical school at Johns Hopkins University, and did a residency in the Barrow Neurologic Institute at St. Joseph's Medical Center in Phoenix. I also completed some subspecialty fellowships, including a fellowship in tumors at MD Anderson Cancer Center here in Houston. Then was in practice for 15 years in Southwest Florida and returned to the Houston area this summer. So deep brain stimulation is an operation for Parkinson's disease and a disorder called essential tremor. It was FDA approved in the late 1990s. It's become much more widely used in those patients in the 2000s, and in the last 2 decades has become almost a standard of care for patients with Parkinson's disease that have the appropriate symptoms that can benefit from the procedure, as well as for patients with very disabling form of essential tremor, which is a different disease that is characterized mainly by tremors with action and movement, but doesn't have some of the other disabling features of Parkinson's disease. What the surgery accomplishes is delivering a very low voltage electrical stimulation to a very sensitive part of the brain that allows to reorient some of the motor circuitry of the brain. Motor circuitry is the part of the brain that controls movement and the control of movement, the fluidity of movement, and the precision of movement. And by delivering the low voltage electrical stimulation to these parts of the brain, we can improve patients' symptoms, particularly tremors, rigidity or stiffness, and fluidity of movement in Parkinson's disease. It's not a cure for the disease, but it is a dramatic benefit to what can often be the most disabling symptoms of that disease. We have a program here at Memorial Hermann, the Woodlands Medical Center, that involves a specialized movement disorder neurologist who can perform evaluations, medical treatment, and maintenance and programming of DBS when it's implanted. We have a neurosurgeon, myself, who's performed hundreds of these procedures. We have a physical therapy, occupational therapy team, as well as a neurocognitive team that does cognitive assessments on these patients. So by having this whole team in place here, we're able to offer this procedure in a community hospital setting, but with a tertiary hospital level of service and excellence in the procedure. We have now experience with thousands of patients worldwide with this procedure, so we know that it's safe and effective. We also know that it's durable because now we have patients that were in the original FDA trials in the 90s that are now over 30 years out, and we know that the benefits of the therapy don't disappear or fade and that they are maintained many years after the surgery. Well, that's changed over the years, and actually one of the great things about offering it in this community hospital setting with experienced practitioners is that we've been able to streamline this. It used to be back in the old days, I was actually part of one of the centers that did the FDA trial. This was an all-day, 7-hour operation. Fast forward to now, and we're now getting it done in usually 2.5, 3 hours. There is a portion of the surgery where for many patients we will actually have them wake up for 30 or 40 minutes as they're being operated upon, so we can talk to them and we can test the movements in their arm, we can test the tremor. That portion, that awake portion, which used to be several hours, we now have down to about 30 or 40 minutes. And typically the hospital stay is 1 night or 2, and the time that it takes to have the device programmed and activated, which is all done non-invasively after the surgery in the office setting. It's usually done with a remote control, and now the companies have developed software that just puts them on Apple or Samsung tablets. That programming time frame is usually 2 to 3 weeks after the surgery for one session that takes about an hour, and then a couple of other sessions 1 month and 3 months later for tune-ups. One of the wonderful things about the way this technology has evolved is that now we have some degree of control in terms of fine-tuning the stimulator that we can give to the patient themselves. So the companies now provide the physician with a tablet like this, and each patient gets essentially a cell phone or an iPod version of this, and patients are able to do some degree of adjustment to their DBS implant on their own at home. For example, I have one patient who turns the device on a slightly different setting when he's having a meal because he needs his tremor controlled at a different level when he's using utensils for cooking, and then a slightly different setting when he's walking a lot because there's different ways of stimulating that have better effects on the walking versus the tremor. We also had a patient back in Florida who, and you're able to name these settings in the patient's tablet, so we can give them a name rather than just calling them setting 1 or setting 2. One of them, he wanted the setting called golf because that was the setting he used when he was putting, and it helped his tremor then. Of course, this is all done with physician supervision so that it's safe and that there are parameters set that the patient will never be able to set a dangerous setting or to deliver too much voltage. But the time frame for the surgery now down to about 2 to 3 hours, hospital stay now down to 1 or 2 nights, and overall in and out of the office for programming, usually a few weeks after surgery, one session for an hour, and then a couple of other sessions thereafter, and then usually a check-in every 6 months to a year. Well, the main thing we hear from people is that they are able to do activities of daily living that require fine motor control and control of tremor, that a lot of things that we might not think about. So a lot of the patients that come to me for the surgery are no longer able to fill out their checkbook, and they have to have their spouse do that. After the surgery, they regain the ability to do that. We do have some patients that aren't able to feed themselves because of tremor in the hand, and after the surgery, they regain the ability to do that. We also see some patients that are disabled socially from doing hobbies that they enjoy. So we have several male patients they have a wood shop, they were craftsmen, they were able to go back to using the wood shop after they regained the fine motor control. I had a lady in her 70s who had really enjoyed fine arts, and she sends me these drawings periodically now that her tremor's gone, that she's able to do these again. The other benefits besides fine motor control of the hands and tremor that we see in Parkinson's disease is the ability to take less medication, because all severely affected Parkinson's patients are on medications. Those medications in and of themselves have some side effects, and after DBS surgery, we usually find a dramatic reduction in the requirement for medication. Well, I think it's a tremendous benefit for patients who like to be close to home and in a setting where there's a little bit more focus on clinical experience, clinical efficiency, although we're not as much of a research or a teaching hospital, so there won't be medical students, residents, or research going on. There's more focus on the patient experience and having the patient have the safe, efficient, and comfortable experience with the surgery possible. Generally, it has to be patients that have been affected either by Parkinson's disease or by essential tremor for at least 3 years, who have attempted medication treatments during that time and have found that their symptoms of movement problems like tremor, rigidity, lack of fluid movement are still disabling despite appropriate medical treatment. We also have some disqualification criteria in people who ought not to have the surgery, people with severe memory issues or dementia, or people with a very, very severe balance problem. But fortunately, that's a small minority, and the majority of patients are candidates. And one of the more important things is to have a experienced and knowledgeable movement disorder neurologist to screen the patients, make sure that the medical treatment has been appropriate, and then explain the benefits of surgery and have them referred for that. And that's what we have here with our team with Dr. Boyle. Yeah, so I should mention, as part of that team, which I mentioned, the surgeon, the neurologist, the therapist, you also need an excellent team of operating room personnel with the right equipment in the operating room. And there was a big investment made here by Memorial Hermann, the Woodlands Medical Center, over the summer to invest in that equipment and in training that personnel. And now we are up to snuff with the most modern and brand new equipment to perform this procedure at the cutting edge level that it demands.